That's great. Thanks so much. Laurel, you're up next, and hold your questions, write them down, and we'll have a look at the end. We'll have plenty of time.
Great. Good morning, everybody. So I'm Laura Gottlieb from the University of California, San Francisco. Many thanks to Bruce and Mark for kicking us off this morning. If you think I'm not going to talk to my 5-year-old about why she has to go to college, oh boy, I have a lot of data now. So thank you, Luke. She's just really smart. We could do this. So I'm going to steer us in a slightly different direction. I'm going to talk about some practical opportunities to integrate upstream and downstream approaches to population health this morning. So first, just a brief overview of what I want to talk about this morning. First, my work is all about integrating social determinants of health into the healthcare context. So I'll offer a rationale for why I think it's important to work within the healthcare system, in addition to outside of the healthcare system. And then I'll talk about some innovations that are already occurring in the healthcare delivery setting. I'll talk about some barriers to work in the healthcare setting, and then some opportunities to move past those barriers. So let's start with the rationale for this work. Why should we work on upstream issues in the context of a traditionally very downstream discipline? So here I draw a lot on Don Berwicks' model from the Institute for Healthcare Improvement. I think this model is actually very applicable for understanding why the integration of social and medical care delivery is so important. Don Berwick created this model called the Institute for Healthcare Improvement. He works at the Institute for Healthcare Improvement, triple aim, and it outlines 3 major domains through which healthcare has to simultaneously advance to reach its ultimate goal of improved population health. And I think if we look at each dimension of the model, there's really some clear advantages to integrating social determinants. So first, whether you believe it or not, the healthcare system and population health actually have quite a number of shared values. So healthcare systems have even started to adopt the term population health. And though, as some people in this room have pointed out, the definition of population health from within the healthcare system and amongst population health scientists is sometimes different, nonetheless, the term has increasingly infiltrated the healthcare delivery system. The second arm of the triple aim relates to costs. And here I'm going to invoke the comments of the famous bank robber Willie Sutton, because it is true that the healthcare system is where, like banks, is where the money is. So the healthcare system reports annual expenditures of approximately $2.7 trillion. If we successfully convince the healthcare system that about our broader definition of population health, we actually have the opportunity to move some of those resources, those $2.7 trillion, further upstream. But why do I think we could actually make that happen? Well, to date, healthcare system activities have failed to slow or even stabilize the rises in healthcare costs. But with the outpouring of social determinants research that many of you have pioneered, we actually see the healthcare system moving increasingly towards social care innovations to think about how to reduce costs, particularly for low-income populations. So the third arm of the triple aim has to do with the patient experience of care. And I would argue that one of the other rationales for working within the healthcare system is not only is it where the money is, but it's where the patients are. So 3/4 of American adults actually have a healthcare provider visit each year. And if we truly want to reach patients where they are, we actually have to go there. It gives us an unprecedented opportunity to actually find patients and help them address the underlying reasons for medical conditions that we might be seeing in the clinic, whether those reasons have to do with traditional or could be responded to with traditional medical care or with social care. So I want to add here that Tom Bodenheimer at the Center for Excellence in Primary Care has helped us reconceptualize the healthcare triple aim, and he now talks about the healthcare quadruple aim. So this model actually incorporates the provider experience of care as a fundamental component of advancing health in the United States. So our research group at UCSF actually now has some new data showing that the capacity to address social determinants from within the healthcare setting actually impacts provider burnout and helps to improve retention, which itself can impact the costs of healthcare delivery and the safety net. So finally, there's certainly the potential for the integration of social and medical care to impact research opportunities. If we are better able to systematically collect data on social needs in the context of healthcare delivery, we might be able to merge those data sets. I imagine that a few people in this audience have had difficulty collecting healthcare data in the past. This could be a way to improve the integration of data sources. So the IOM has weighed in on this issue before. They've talked about how important the integration of social and medical care is. A 2012 report from the Institute of Medicine's Committee on Primary Care and Public Health talked about the range of degrees of integration between these two disciplines, ranging from isolation and mutual awareness on the left of the spectrum to partnership and merger on the right of the spectrum. And I would say since that 2012 report, we've actually come quite a ways, moving from a mutual awareness to much more concrete opportunities for collaboration. So I'm gonna, yeah, that's great. So it's not just the IOM, So just this year, actually, the IOM Committee on Recommended Social and Behavioral Domains to Include in Electronic Health Records actually published a report that has received a tremendous amount of attention from healthcare providers and from payers who are preparing for this increased integration. So listed here are some of the domains this committee recommended to include in all electronic health records across the United States. And you'll see that for the first time ever, they're recommending that we collect information on education and on individual financial resource strain, on neighborhood level income as well. And I want to note that healthcare systems are really hungry for this kind of data. Or these kinds of tools, rather. My colleague Rishi Manchanda and I, through a nonprofit, Health Begins, recently published a similar list of social domains to collect in the electronic health record, and within 2 weeks of putting that tool online, over 400 different healthcare systems had downloaded the tool. So really, it's not just the IOM and high-level committees that are interested in this integration of social and medical care delivery. It's grassroots healthcare providers on the ground who recognize that this integration is critical. So this is a word cloud that our research team at UCSF put together based on a comprehensive literature review and a series of over 50 key informant interviews with experts in the field. So you can see that interventions are already being done on a range of social issues inside the healthcare delivery system. And these kinds of interventions include housing access, housing habitability issues, childcare, transportation, food insecurity, financial security. Staff models for this integration include things like case management, care coordination, community health workers, social workers, things that may be familiar to you in the healthcare context, but that you don't think about explicitly as the integration of social and medical care. So as our group examined the existing research in this field, we pulled out several important themes. So much of the practical work in this area targets high-utilizing patients. So for example, the Camden Coalition and Jeff Brenner's work in New Jersey is an example of this because costs are such an important focus of our healthcare delivery system right now. Many of these interventions involve a combination of social and medical care delivery, kind of throwing the kitchen sink at the problem of the costs of low-income care, of care for low-income populations. So in other words, a community health worker might connect a patient who's discharged from the hospital with primary care, but at the same time, they might connect them with housing or food resources. But very rarely are the social interventions described in the literature. So finally, while we discovered quite a bit of innovation in this field, we found remarkably little evaluation. The studies that we did find are primarily descriptive or observational. There are very few randomized trials. Again, they rarely talk about what the added value specifically of the social intervention might be on healthcare outcomes. And many of these studies only include process outcomes or social determinants outcomes, so a change maybe in food security, but they never talk about the health or rarely talk about the health impacts or the healthcare utilization impacts of this work, which is really important to sell this to a broader audience in the healthcare delivery system. So based on the assumption that the integration of social and medical care is critical to advancing the quadruple aim, we went on to think about the challenges to scaling this work. And I like to think about this in three big buckets. The first bucket is provider capacity, or frankly, provider lack of capacity. So part of addressing this problem demands ensuring that the health professional workforce has an understanding of social determinants of health and health disparities. But frankly, and the few clinicians who are scattered around the room will understand this, we already have a major workforce shortage around primary care, particularly in the United States. And physicians, nurse practitioners, physician assistants are not the best ones to do this work. What we have to do in the healthcare system is identify the right workforce and bring those people in, whether figuratively through partnerships with community agencies or literally into the healthcare workforce. A related but distinct second barrier has to do with clinic capacity. And this challenge to scaling the work involves developing the capacity for electronic health records to incorporate social screening tools, social screening templates. It also demands changing our quality improvement processes so that we can track social needs over time and can be held accountable for changes. Clinic capacity also involves funding this work, and I'll talk a little bit more about that at the end of the presentation. So the third important barrier to scaling this work relates to building an evidence base that documents why it's important to work within the healthcare setting. In our background work, as I mentioned previously, we found a lot of innovation, but almost no evaluation. So if we really want to activate the healthcare system, we have to document how this works. And I'm going to spend my last few minutes today just talking about one way that we've tried to improve the evidence base for this work. So in 2013, we embarked on a randomized control trial in collaboration with partners at San Francisco General and UCSF Benioff Children's Hospital in Oakland. Both are safety net hospitals serving low-income families. The intervention that we used was adapted from a program that was originated in Boston called Health Leads, and that has been supported by the Robert Wood Johnson Foundation. In the intervention, undergraduate and community volunteers are incorporated into healthcare systems, and they conduct routine, systematic social screening with families, and then they try to connect families with any identified needs to existing community, government, or hospital-based resources related to those needs. So our intervention actually incorporated an additional professional tier, both of social work and free legal services. Those people provided training for our volunteers, and they also provided backup for patients whose needs were so complex that they exceeded the capacity of the volunteers. So our trial included an active control condition where families randomized to the control group still received more than the standard of care. They actually not only underwent systematic social screening, which is not currently done in our healthcare system, but they also received written resources related to any identified needs. So the study just closed, so these results are hot off the presses. We enrolled families across those 2 safety net hospitals that I mentioned. We enrolled a few more than 1,800 families, both from primary and urgent care. We had almost 60% Latino patients, 25% Black patients. 75% of the households in our final sample earned less than $35,000 a year. So this graph shows a significant decrease in the number of social needs. So we actually did what we were aiming to do. So you see the intervention group results on the right and the active control condition on the left. Over half of the patients in our intervention group averted at least one social need, and many averted more than that. Great. We also found a significant improvement in a 5-point scale of parent-reported child health in the intervention group on the right in comparison to the active control. Again, this is the first randomized control trial of a social services intervention run by volunteers, and it's the very first study to include child health outcomes in the array of outcomes studied. So as you can imagine, I'm pretty excited to share these results. And you're my first audience for that, which is even more exciting. So I'm going to start to wrap up by saying that there's some really exciting work emerging around bridging non-medical determinants with healthcare delivery. But to advance this field, we have to commit to 2 things. And the first is we have to commit to defining and building a national research and evaluation agenda that will help us move past the barriers that we have in this field. And I really think that population health scientists can help us do that. The second front on which we really have to advance is developing some funding models to sustain this work by reimbursing healthcare systems for their efforts to integrate social and medical care. So for instance, we need to restructure pay-for-performance strategies. Our research team, in collaboration with the Pediatric Hospital Information Systems, FIS, has actually shown that existing pay-for-performance strategies penalize safety net hospitals, and that ends up reducing the amount of money that those hospitals have to spend on care for low-income populations. Another possibility would be, and similar, would be to stop the scheduled reductions in disproportionate share payments that safety net hospitals currently receive and are scheduled to end under the Affordable Care Act. And Jeff may talk about that in a few moments, I'm not sure. So those payments help to offset the costs associated with care for vulnerable populations. And lastly, I would say that in our interviews with Medicaid managed care providers with Medicaid managed care payers and with healthcare system providers, that we've heard again and again and again, that increasing the flexibility of Medicaid dollars is critical to care for vulnerable populations. So increasing bundled payments will help providers either partner with external agencies who have the expertise in this area or to bring in the social care workforce that is necessary. And all of these payment models and comparing these payment models are things that healthcare services or healthcare systems need help evaluating to understand the best methods for doing this work. So I had a chance to speak at a forum for health professionals this past weekend, where my closing message was about how important it is to incorporate social determinants of health into the healthcare setting. And now I get this sort of lovely opportunity to talk to population health researchers about not writing off the healthcare system when they think about social determinants interventions. It's where the money is, it's where the patients are, and our values are increasingly aligned. But we definitely need the help of population health scientists to advance this work. So finally, I just want to mention the Evidence for Action funding mechanism, which is a new national program of the Robert Wood Johnson Foundation's Culture of Health. There are many folks from the RWJ Culture of Health program here in the audience, and I would encourage you to talk to folks over the course of today's events about this project. The program aims to fund innovative, rigorous research to build the evidence base necessary to both improve health and to decrease health disparities. The National Program Office is based with us at UCSF at the Center for Health and Community. So this is actually not a non sequitur in relation to my talk. You can see that in the Culture of Health Action Framework, Action Area 4 is specifically focused on strengthening the integration of healthcare systems and health services with the aim of improving equity and population health. And it's really not just because I'm involved in the effort. This is a really purposeful and intentional effort on the part of the Robert Wood Johnson Foundation to try to bring the healthcare system into this conversation around population health. So again, I would encourage you to find us if you're interested in this funding mechanism. So finally, just a few acknowledgments. I just want to do a call out to my close colleagues at the UCSF Center for Health and Community and at Health Begins, at the two safety net hospitals who are our close research partners, and more broadly to the Bay Area Regional Help Desk Consortium, and finally to our funders, including the Robert Wood Johnson Foundation, the Commonwealth Fund, and the Lisa and John Pritzker Family Fund. So thanks so much for joining us today, and have fun at the rest of the conference.